All right. Good morning, everybody. Thank you so much for joining me. We have a jam-packed classroom today. All of you are just, very, I'm sure, passionate about studying for the USMLE. And today I'm going to be kind of going through a very high-yield topic, something that's near and dear to my heart, renal physiology. But first, why don't I have the opportunity to get to know all of you all? Can you type into the chat, where are you all from? I would just love to know either city or country. That would be so awesome. All right, great. Wow, awesome. So we got some US. Oh, India, international audience. Perfect. Pakistan, that is awesome. Colombia, wonderful. Wow. South Texas, excellent, excellent. Perfect. Well, as you guys know, I mean, this exam basically has no borders, and that's the beauty about medicine is, it is so far-reaching, and the profession itself is so noble and humbling. And as myself just finishing residency, it's been absolutely awesome to teach throughout residency and then also take care of patients. So appreciate you all joining me, and just wanted to kind of lay some ground rules before we start our presentation today. Now, if you don't mind muting your audio, it should already be muted. And also, if you have any questions, feel free to put them in the chat box. And towards the end of the session, I will definitely get back to you all with those questions. If you have any issues throughout the presentation, try to kind of mess with the audio or the video. And I will let you know if there's any internet connectivity problems on my end. But sounds like everybody can hear me right now. So that is absolutely awesome. So one question I'm going to ask you all, so you stay active and engaged, because that's what I'm all about. Are you guys pumped to learn some USMLE physiology? Let's go for it. As I'm just have to make it as exciting for you as possible. So are you guys all pumped? All right, Tina is pumped. Look at that. All right. All right. I'm getting a lot of yeses. So that is great. Well, first off, I just want to start off by just saying thank you so much. I mean, I started this High Guru kind of project and community a little over a year ago officially. And it all just came from a passion for teaching. A little bit about me and my good friend, David Shaffron. So I am actually a now graduated pediatric resident, and I'm a soon-to-be fellow in pediatric intensive care. So I'm going to be starting actually at the beginning part of this July. So I'm actually very, very pumped. And David actually is a attending physician, and he is a pediatric nephrologist by training, and he does see general pediatric patients as well in the Cleveland, Ohio. But more importantly, I mean, despite being clinicians, we are two passionate individuals that really want to change medical education. We want to go from a very linear kind of model of learning to something that is integrative, something that is active for you all, right? Something that you can study right now, and then in your clerkships, in your residency, fellowship, you can apply. And I think what's so unique about High Guru is, number one, we are a community. Secondarily, we are very focused on USMLE Step 1 and Step 2 preparation, because honestly, that's kind of a stepping stone to get to your residency, to get to those fellowships, right? We also are going to be very focused at High Guru. We are very focused on active recall. Rather than me just being like, oh yeah, so in pre-renal kidney injury, the BUN to creatinine ratio is greater than 20, for example. I'm going to give it to you in a vignette manner, because guess what? We all have to practice like we play. And when you practice like you play and you learn content and questions at the same time, that is going to be an efficient way of learning. So let's kind of just get into what we're going to be doing today. Well, first, what I'm going to do is give you the organization of the kidney. I'm going to talk about glomerular physiology, some clinical markers of kidney function, filtration fraction, and then what we're going to do is just take a trip into or through the nephron. We're going to start from the proximal convoluted tubule and end in the collecting duct, and everything is going to be very USMLE oriented. Guys, what I honestly did was I synthesized a lot of my own notes as I was going through step 1 preparation from UWorld, First Aid, Pathoma, etc., from BRS and Kaplan, which are big physiology resources as well. So as you will see, this is a very integrative review, and I hope that you stay active and engaged with some questions that I'll be asking. So, put up the chat bar and stay really excited to continue to learn some of these concepts. So let's do it. I'm a very cheesy kind of guy, and I do want to start off with a little bit of an inspirational quote. So remember that true success is achieved by stretching oneself, learning to feel comfortable when you are uncomfortable. So always push yourself, and with that, let's get into it. Now, the first thing that we're going to be talking about is the functional organization of the kidney. Now, as you know, the kidney has anatomic components and it has functional components. And sometimes you can relate the anatomy and the physiology together. Now, what is the basic functional unit of the kidney? I know it's bright and early in the morning. Why don't you guys type it out? Basic functional unit of the kidney. What are we focusing a lot about? Yeah, I got a lot of answers here. Yeah, exactly. Everybody's saying the nephron, and you're absolutely correct. So the basic functional unit of the kidney is going to be the nephron. Now, remember that with the nephron, we have two flavors of nephron. We have the juxtamedullary as well as the cortical nephrons. Now, which comprise a majority? I'm going to continue to have you guys engage. What do you guys think? Majority of nephrons. How many people say juxtamedullary, or how many people say cortical? Type it in right now. What do you guys think? Got one person saying juxtamedullary. Ooh, this is a tough one, right? Yeah, absolutely. So actually, majority of nephrons are actually cortical nephrons, and that's important for you to know. The other aspect of the nephrons are going to be juxtamedullary. So what defines juxtamedullary? Well, juxtamedullary is going to be a nephron in which there are long loops of Henle that penetrate into the medulla of the kidney. Remember, the cortex is on the outside, the medulla is on the inside. And this functional organization of the kidney is very high yield for your step 1. So let's go into it in a little bit detail. Now, as we see, this is going to be a nephron, and the long loops of Henle go into the medulla of the kidney, and that is extremely important for you to know. Now, let's go into an application question. A patient with chronic kidney disease is found to be hypotensive in the ICU. What portion of the nephron is most affected by this acute insult? Now, this question, yes, it's an active recall question, it's an application question, and what I want to really highlight is, yes, in this setting, there may be a couple correct answers. However, when we're talking about the difference between juxtamedullary and cortical, what we have to recognize is that the medulla, from a macro anatomic perspective, has a lower PO2, and it is this medulla that is going to be most affected by the acute insult. Another correct answer in terms of hypoxia to the kidney, decreased blood flow in this patient, hypotension, is going to be the proximal convoluted tubule. USMLE loves for you to know that. Why? Because the proximal convoluted tubule is extremely metabolically active, and thus it is going to be very susceptible to ischemic events. Hint, acute tubular necrosis. Very nice bridging pathology there. So medulla as well as the proximal convoluted tubule are going to be two areas that are particularly susceptible to ischemic injury. Now, the key thing for you to know is that the medulla has these long capillary loops, and these long capillary loops are going to be known as the vasa recta. And the vasa recta are actually a branch of the peritubular capillary system, but we're going to get to that. But the vasa recta are a branch of the peritubular capillary system. Now, what we recognize is that there is slow flow through these vasa recta vessels. And so when there is that slow flow, that keeps the PO2, the partial pressure of oxygen of the medulla, lower than that in the cortex. And when the partial pressure of oxygen in the medulla is lower than the cortex, that is the why, the mechanism. Step 1 is all about mechanism. That is why it is more susceptible to ischemic damage. Now, what portion of the nephron is going to be hyperosmotic? Do we think the cortex or the medulla? How many people say it is the either cortex or medulla? Type that in. Ooh, everybody's getting this answer right now. Yes, Exactly. Very good. Very good. Exactly. The portion of the nephron that is hyperosmotic, that is going to be the medulla. Exactly. Have you guys heard of this concept? Counter current multiplier system, right? The counter current multiplier system, the fact that you can concentrate your urine through various different osmolalities of the medulla, that is extremely important for you to know. Okay. And relatively isoosmotic is going to be the cortex. Very good. All right. So next thing we're going to be talking about is why is renal perfusion important? And let's highlight this concept by going through a sample question. So a patient presents with shortness of breath and peripheral edema. He has difficulty lying flat and exam reveals crackles on his lung exam. So as we read this, what do we think the diagnosis is? Shortness of breath, he has edema, he can't basically lie flat. And some people are typing in the chat, you're absolutely correct. Heart failure, exactly. This is all congestive heart failure. And you guys are like, excuse me, this is the renal review, not the cardiac? Well, remember the body's all connected, right? So the likely presentation here is congestive heart failure. And as you can see, this patient has signs of fluid overload. Now, if we continue on with this vignette, the patient's ejection fraction is markedly low, i.e. under 55%. And his cardiac output is calculated to be 2 liters per minute. Normal cardiac output, about 4 to 5 liters per minute. So this patient has severely compromised cardiac output. Now, what percent of this cardiac output will the kidneys receive? And so what is very important for you to know is that the kidney receives about 20 to 25% of the cardiac output. And I think that is extremely important for you to know, okay? And if we apply this, this patient has a kidney blood flow or a renal blood flow of 0.5. Why? Because here's the cardiac output, and 25% of his cardiac output is going to be his renal blood flow. And that is really, really important because as you can see, normal renal blood flow is about 1.1 liters per minute, okay? 1.1 liters per minute. And that comes from the fact that it is about a fourth of cardiac output. So this is extremely important for you to know for your USMLE questions. And this is all going to be related to how cardiac output is related to renal perfusion. All right, excellent, wonderful. So the next thing that we're going to be talking about is not only looking at the cortex and medulla, but we're going to dive into where the USMLE really likes to ask a lot of questions. And that is going to be at the level of the nephron. We have to first get some basic terms out of the way though. As you can see, blood comes in from the afferent arteriole and is going to leave via the efferent arteriole. And here's the glomerulus, right? Now, after the efferent arteriole, this is an important point right here. And not many students know this, and I really want to highlight this. The efferent arteriole, yes, it goes back to the heart after a while, right? But the efferent arteriole, extremely important for you to know, is going to actually continue as the peritubular capillary system. Make sure you recognize that the whole aspect of reabsorption of ions, the reabsorption of the ions from the P area here, PP area, into the actual bloodstream is going to be into the peritubular capillaries, peritubular, surrounding the tubules. And that's high yield for you to know, okay? And we're gonna toy with this concept in the next slide. Now, go back to what we're comfortable with. Yes, this is the glomerular capillaries. Yes, this is the Bowman's space, the Bowman's capsule, okay? And what do you think process 1 is? Process 1 is when you are coming out of the glomerular capillaries, and that is going to be filtration. Exactly, that's going to be filtration, excellent. Now, what is going to be process number 2, i.e. from the P into the peritubular capillaries, and that is going to be reabsorption. Exactly, very good. So filtration, reabsorption, and if you go the opposite way from the peritubular capillaries into the lumen of the nephron, you are going to have secretion. And finally, number 4 is going to be excretion. And so mathematically and conceptually, if we think about it, excretion is going to be equal to your filtration minus what you take out plus what you are going to add. Let me say that again. All right, so here you have a bucket of money, right? I'm filtering that bucket of money. Okay, fine, take some out for taxes. Oh, but put some back in because I was earning something from my side hustle. Okay, so that is excretion, is okay, filtration minus what I took out, plus, hey, what did I add back in? So this is a nice step one esque question. And I want you all to read this question and type into the chat box, what do you think the answer is? So what change tends to increase peritubular capillary fluid reabsorption? I'm gonna take a nap for 30 seconds and feel free to answer in the chat box. All right, we're getting some E, we're getting some A's, ooh, C's. Ooh, can we get some more? I know there are more people here. All right, so a lot of E's. Actually, you know, the answer is, and we got a couple of C's as well, the answer is going to be C. All right, so let's actually kind of go through this and why this is really important. Increased peritubular capillary fluid reabsorption is going to be all related to, particularly, where we have the configuration of the efferent arteriole, what the configuration of the efferent arteriole is. Afferent, efferent, and peritubular capillary system. Now, if you have increased efferent arteriolar resistance, this efferent is going to squeeze down. So afferent, efferent, and the efferent is going to tighten up. And when that tightens up, you have increased amounts of glomerular pressure and subsequently increased amounts of GFR. Now, the fluid that is left here, it's like squeezing that sponge. That fluid actually is not even there because, hey, guess what? We put it out here where the GFR is supposed to be. And what happens as the blood goes and becomes a peritubular capillary system, it becomes very rich in proteins and subsequently has a very high oncotic pressure. And when it has a high oncotic pressure, it is going to cause you to reabsorb more of the fluid and more of the ions because there's a higher gradient between the lumen of the kidney as well as the peritubular capillaries, which now has an increased oncotic pressure. And that's high yield for you to know. Now, increased renal blood flow may not directly increase the peritubular capillary fluid reabsorption. It just is going to increase the GFR. But if you squeeze down on the efferent, more glomerular filtrate is going to be coming out, and you have a higher oncotic pressure, a pulling pressure in the peritubular capillary space. And that's high yield for you to know. Now, put it right here at the USMLE. Increased efferent arteriolar resistance, they can say, oh yeah, increased levels of angiotensin II. Any state, any clinical vignette that is going to activate RAS. Okay, so these are the two scenarios. And as we know that RAS and the angiotensin II concentrations are going to affect the efferent arteriole. All right, continuing on. When we talk about the glomerular physiology, I want you all to answer this question. So a patient is found to have elevated angiotensin II concentrations. What effect would this have on glomerular hydrostatic pressure? We just actually talked about this. What do you guys think? What effect would increased angiotensin II concentrations have on glomerular hydrostatic pressure? I'm seeing a lot of yes, very good. It is going to increase. And the mechanism here is that you have efferent arteriolar constriction. Let's go through it again. Afferent, glomerulus, efferent. If you have constriction of the efferent, you are going to cause a lot of glomerular back pressure, and that is going to increase your GFR and obviously increase your glomerular hydrostatic pressure. Now, a patient is placed on NSAIDs for osteoarthritis. This is a very high yield USMLE vignette. Now, what effect would this have on glomerular hydrostatic pressure? Ooh, this is interesting. So NSAIDs, go through what the mechanism of action of NSAIDs is. NSAIDs is a COX inhibitor, And downstream, as it affects the arachidonic acid pathway, it is going to reduce the amounts of prostaglandins. If it reduces the amount of prostaglandins, guess what? Your afferent arteriole is not going to stay as open. Afferent arteriole is not going to stay as open because remember, prostaglandins vasodilate things. And if your afferent arteriole is not going to be as open, guess what? Well, you're going to have decreased glomerular hydrostatic pressure. So the mechanism here is that when you inhibit prostaglandins by giving NSAIDs, you are going to decrease glomerular hydrostatic pressure because prostaglandins, normally prostaglandins keep the afferent arteriole open. Summary here, afferent arteriole under the control of prostaglandins. Efferent arteriole under the control of angiotensin II. And I love for you to make that distinction in your mind because USMLE questions are going to kind of play with that adage, okay? For example, the NSAIDs question, we're going to be talking about the afferent. For example, increased amounts of aldosterone secondary to increased amounts of RAS, that's going to be the more efferent, okay? Excellent. So let's kind of go through this a little bit more, and these are all from your high yield resources. As we see, if we constrict the efferent arteriole, as we constrict the efferent arteriole, which is right here, you are going to increase your capillary glomerular hydrostatic pressure and increase your GFR. And that is extremely high yield for you to know. Actually, one of the other questions that they can ask is a diabetic patient who comes in with proteinuria. Why is that? Well, as you remember from pathoma, in diabetes, you have preferential non-enzymatic glycosylation of the efferent arteriole. And that preferential non-enzymatic glycosylation of the efferent arteriole is going to cause you to have a narrowed efferent arteriole, a subsequent higher glomerular capillary pressure, and an increased amounts of GFR. Yay, the diabetic had increased GFR. Well, if that stress continues for a prolonged period of time, well, guess what? The response to cellular stress is going to be to hyperproliferate the mesangium, but also after a while, the stress is going to outweigh the compensatory mechanisms, and actually we are going to have micro or even macro albuminuria. And when you have micro or macro albuminuria, that is going to kind of represent that there is some element of glomerular damage, and that is probably due to the non-enzymatic glycosylation of the efferent arteriole causing that back pressure. And so a classic USMLE question is that if you see a diabetic with proteinuria and they have hypertension, for example, the best medication to use is ACE inhibitors or ARBs. And the reason why is because ACE inhibitors and ARBs reduce angiotensin II concentrations and thus reduce the efferent constriction, subsequently decreasing the glomerular capillary hydrostatic pressure. Okay, very important, and I want to integrate all of this in as we are preparing together. Very good. All right, so this slide is straight from BRS, and what this basically tells us is that if you have increased efferent arteriole constriction, you are going to have a higher oncotic pressure in the, where? Peritubular capillaries. There they are again. And that higher oncotic pressure in the peritubular capillaries is actually going to cause us to reabsorb more water and reabsorb more ions. The gradient is going to be more favoring for reabsorption. That makes sense. In a very stressed state, in an increased aldosterone state, in a sympathetic state, you want to actually hold on to things. And it's all based on the fact that you squeezed a lot at the efferent arteriole. Now, this goes back to our question with the NSAIDs. And the NSAIDs, remember, reduce PGs, prostaglandins. And if NSAIDs reduce prostaglandins, you get constriction of the afferent arteriole, less blood going into the system, you have less glomerular capillary hydrostatic pressure, and you have decreased GFR. And so on the USMLE, whenever they have a patient who comes in and in the vignette, they say, a patient with history of osteoarthritis, I want you all to think in your mind, hey, make sure they're not testing me on the complications of NSAIDs. Complications of NSAIDs, let's go. Kidney is one of them. Decreased afferent arteriolar kind of tone, and you're going to have constriction of the afferent arteriole and subsequent decrease in renal blood flow. Second question that they can ask is going to be that, hey, NSAIDs affect platelet aggregation. Yeah, NSAIDs affect platelet aggregation. And so that could actually cause these patients to bleed a little bit more. Third question that they could ask is NSAIDs can cause a gastritis picture. And that is because prostaglandins are very important in increasing the mucus, that mucus layer of the gut. And so when you have reduced prostaglandins, reduced mucus layer, acid can then win and you can have that irritation. So as you can see, from NSAIDs, I kind of took all the different vignettes and kind of packaged them together for you because I want you all to learn in a clinical, vignette-based, application, mechanistic way that is very integrative. All right, very good, excellent. Are you guys hanging in there? Let's get like a whoop whoop or a yes, yes in the chat box. All good. Yeah, very good. Wonderful. Wonderful, wonderful. All right. And those people who have their hands raised, I will definitely answer all of your questions. I will definitely answer all of your questions as soon as I'm done. But yep, perfect. Excellent, excellent. Wonderful. All right. So continuing on, a patient with diabetes is, oh, sorry about that. A patient with diabetes is found to have a blood pressure at the outpatient visit of 145/94, so a little elevated. He has started on an ACE inhibitor. What effect would this have on glomerular hydrostatic pressure? ACE inhibitor, what effect would that have on glomerular hydrostatic pressure? Let's get a up or a down in the chat box, up or a down. And you guys are all understanding the concept. Yes, yes, yes. Very good. Decreased. Mechanism here is ACE inhibitors inhibit angiotensin II, and that mediates the tonic control of the efferent arteriole. Very good. Excellent. All right. Next concept we're going to be talking about are two. Okay. One is going to be GFR and knowing renal plasma flow and renal blood flow. Now, what is going to be the normal GFR? Well, the normal GFR is about 120 mLs per minute. Do you need to know that number like right off the top of that? No, but at least it gives you some context, okay? A patient is found to have a low GFR. The medical student, what an awesome medical student, would like to manually calculate for his patient the GFR to impress the attending. Nice. What is the ideal substance the medical student can use to measure this value? So the ideal substance to measure the GFR is actually going to be inulin. Yeah. And the unique property of inulin, the most ideal substance, is that inulin is filtered, but it is not reabsorbed or secreted. It is the true marker of GFR because, again, it is filtered and nothing is touching it. You're not taking it out or you're not putting anything back in. And that means that the clearance of inulin, clearance, which is basically the urine concentration times the volume of urine over the plasma concentration, the clearance of the inulin is equal to GFR. Okay, very important for you to know. Now, what segment of the nephron has the highest concentration of inulin? And that is basically where there's less water, because the less water in the lumen of the nephron is going to mean that there's a high concentration of inulin. And where do we concentrate majority of our urine and, hey, majority of inulin? Well, yeah, in the terminal collecting duct, exactly. In the terminal collecting duct, remember, those aquaporins insert and cause you to reabsorb more water. Now, the segment of the nephron that has the lowest concentration of inulin actually is going to be in the Bowman space. There's no reabsorption of water, and this is going to be filtrate that is going to have both water as well as inulin. So clinically, what we use to help us evaluate GFR is going to be creatinine. Exactly. The clearance of creatinine is going to be the practical or the clinical marker we use. Now, the unique property of creatinine is that creatinine is going to be filtered just like inulin, but hey, guess what? There is some secretion. Whereas inulin, there was no secretion, but hey, creatinine, there is a little bit of secretion. And so based on this, we will kind of understand that creatinine is actually going to overestimate your GFR by about 10%. Creatinine, because there's a little bit of secretion, it overestimates your GFR by 10%. Next concept we're going to be talking about is going to be renal plasma flow. Now, renal plasma flow is about 600 mLs per minute. Okay, fine. Do you have to know that number? Memorize it? I don't know. But guess what? I first want to just talk to you from a hemonc perspective. What is plasma? Well, right now, if you kind of cut your skin and you saw the blood, and from the blood, it's like you were in a grocery store and you said, let me take out RBCs, let me take out WBCs, let me even take out the platelets. You would be left with the extracellular matrix of the blood, and that is going to be plasma. So plasma is the extracellular matrix of the blood. There's no RBCs, there's no WBCs, and there are no platelets. And what we understand is that plasma makes up about a little over half of the total blood volume, of the body's total blood volume. And remember on our first slide when we said the renal blood flow is about 25% of cardiac output? Remember we said the renal blood flow is about 25% of cardiac output. And this renal blood flow is about 1.1, right? That's 21% or 25% of that 4.5, about 25% of that 4.5 liters per minute of cardiac output. So that's where we got that 1.1. If you take 1.1 and you put 55 or multiply it by 0.55, which is amount of plasma, that's where we get the 600 from, okay? So is this going to be like tested like directly on the Usmle? No, but it's all conceptual, right? You understood that 25% of cardiac output is going to be renal blood flow. Well, what percent of the blood is plasma? About 55. So 1.1 times 0.55, well, that's renal plasma flow, okay? Excellent. So a patient is found to have a low renal plasma flow. The medical student would like to manually calculate this for his patient to impress the attending. All right, what is the ideal substance that we use to measure the renal plasma flow? The ideal substance that we use to measure the renal plasma flow, a lot of people are chiming in right now. Yes, you got it. That's going to be PAH. And the unique property of PAH is that it is going to be filtered and secreted, but not reabsorbed. Filtered and secreted, but not reabsorbed. Nothing's taken out of it. So what I want to kind of simplify for you and say, in other words, not all of the PAH crosses into the primary filtrate. Can you believe it? Well, yeah, some goes into that peritubular capillary system. After the efferent, a little bit of PAH goes into that peritubular capillary system and is subsequently secreted, as you can see. PAH filtered and secreted. Now, that means that the venous PAH concentration is not zero, right? Because I said it goes in the afferent. Yes, majority of it goes and gets filtered. But then what about a little bit in the efferent? Yeah, well, there is a little bit in the efferent and subsequently in the venous system. And what we recognize is that the venous PAH concentration is about 10% of the arterial PAH. And all I'm trying to tell you is that renal plasma flow, if we use PAH, because there's some unaccounted for PAH, it is actually going to be underestimated, okay? So let's kind of synthesize all of this the high guru way, right? GFR, the GFR is going to practically be measured by creatinine clearance. Creatinine filtered and secreted, and because there is a little bit of secretion, creatinine overestimates the GFR by 10%. Renal plasma flow is going to be the UV over P, which is the clearance of PAH. And remember, PAH is freely filtered and secreted, but there is some venous concentration. And because there's some that is unaccounted for, PAH clearance underestimates renal plasma flow by about 10%. All right. Now what I'm going to be doing is giving you a little application question concerning the measurement of renal plasma flow and GFR which of the following are true? I'm going to take a nap. 30 seconds. I'm just going to take a nap. And you guys go through, read the answer choices, and type in the chat box. Type in the chat box what you think the answer is. All right. We got a lot of mixed answers. Yeah, excellent. Well, the answer is going to be E, and this is directly from BRS physiology. And essentially, what I want you to recognize is that, yes, inulin is a good marker for GFR, and that's because it is not reabsorbed or secreted by the renal tubules. Now, as you go into the proximal tubule, the fluid itself overall is isoosmotic. The fluid itself is isoosmotic, but remember, your osmolarity is primarily defined by sodium concentration, urea concentration, as well as glucose concentration. And so inulin concentration in particular, as you are going to reabsorb water in the proximal convoluted tubule, the inulin concentration increases progressively, okay? And that's because, yes, the fluid itself is isoosmotic, but if inulin necessarily doesn't play into the osmolarity of a fluid. PAH is a good marker of renal plasma flow. We talked about that. It is freely filtered, and a very little PAH reaches a renal vein, and that's why we say it underestimates renal plasma flow by about 10%. Okay, awesome. So we're learning some good facts, and we're going to continue on with our review and talk about renal blood flow. Now, the relationship between renal plasma flow and renal blood flow is the following. Well, renal blood flow is going to be the equation for renal blood flow is going to be renal plasma flow divided by 1 minus hematocrit. How I kind of just remember this is I say, hey, renal blood flow. Well, renal plasma flow is the plasma is basically blood without all of the different stuff. So 1 minus hematocrit kind of adds all that stuff back in. So renal blood flow is renal plasma flow over 1 minus hematocrit. Just add all that RBCs, platelets, WBCs that we took out for making plasma. Now, this is extremely important for your step 1, and that is going to be the relationship between renal plasma flow as well as GFR. Now, renal plasma flow and GFR, the relationship is best described by the filtration fraction. We're going to have an application question that the USMLE can test, but I want you to know that GFR over renal plasma flow is filtration fraction. Don't memorize, please understand with me. Of the plasma that comes to the kidney, or of the plasma that comes to the glomerulus, how much of it is filtered? Let's say that again. The filtration fraction is a fraction of what comes in, renal plasma flow, that is filtered across the glomerular capillaries. So basically, what comes in, what percent of that is going to be kind of filtered out? So filtration fraction, extremely important concept. And as we can see, the normal filtration fraction is 20. Ooh, 20%. All right, let me take out my iPhone real quick. GFR was 120, right? And the renal plasma flow, so can I just say it right here? GFR over renal plasma flow. GFR, 120 mLs per minute. I was like, don't memorize it. You guys all memorized it. And renal plasma flow is about 600 mLs per minute. 120 divided by 600. So 120 divided by 600 is equal to 0.2. So that's where we get the filtration fraction being 20%. And so what happens to the remaining 80%? Well, it becomes that peritubular capillary system, because that's the stuff that is not filtered across, but continues in the efferent and subsequently through the peritubular capillary system. So let's go through this. A patient with low blood pressure is found to have activation of RAS. What effect does this have on peritubular oncotic pressure? Guys, stay active and engaged. What do you guys think? Up or down? Answer this question. We have so many people in this room. It's busting open today. All right, Shubham, awesome. Remember, activation of RAS. I'm getting some decreases. Answer is going to be actually increases. Let's go through this, okay? Again, I can't just sit here and read you first aid. I'd be doing you a disservice if I just, in a linear way without application, renal plasma flow, I'd be doing you a disservice. Let's go through this. Afferent, glomerulus, efferent. RAS, remember, constricts that efferent a little bit more than the afferent. Preferential constriction, right? Angiotensin 2. And you squeeze more GFR out, more fluid out, and in the peritubular capillary system, because you squeezed all that fluid out, the oncotic pressure, the pulling pressure, is going to increase. And that's why in that state, you're reabsorbing more. Very important concept. And the explanation is that increased peritubular capillary oncotic pressure downstream is going to translate to increased proximal tubule reabsorption, okay? Because it's a more pulling gradient. Very good. Excellent. Excellent. And this just says efferent arterial and then peritubular capillaries. Here we have an old man who presents with flank pain and hematuria. Anytime I see flank pain and microscopic hematuria, flank pain plus microscopic hematuria, I am particularly thinking about nephrolithiasis on the USMLE. Exactly, stone. Very good, Shubham. On CT, he is found to have dilation of the right ureter representing obstruction. What effect will this have on GFR, renal plasma flow, as well as filtration fraction? So I will go through and answer this question for you. As you can see, this is going to be the kidney, and the glomerulus is within the kidney. There's a stone right here, and that is causing a lot of back pressure. Now, that back pressure is going to decrease our GFR. Again, if we look at the glomerulus, the true explanation is we have increased hydrostatic pressure of the interstitial fluid or of the Bowman space, same thing. Increased hydrostatic pressure of the interstitial fluid or the Bowman space, and that is because of the obstruction, the post-renal obstruction that we have. Now, typically, this doesn't change your renal plasma flow until much later. If you have much severe damage, then you're going to actually change your renal plasma flow. But if you decrease your GFR and you basically, at this point, don't change your renal plasma flow, the kind of concept that I'm going to be illustrating to you is that you have a decreased filtration fraction. And that's because of this whole paradigm, okay? So as you get the actual intrarenal damage, yes, your renal plasma flow can decrease, but the whole notion is that because you increase the hydrostatic pressure of the Bowman space, you are going to be getting a reduced GFR. All right, excellent. Next concept that I want to illustrate to you is going to be the concept of splay and glucosuria. Very good. Obese woman is found to be diabetic. Her fasting glucose is 253. What will a urine dipstick likely show? Well, the concept that I'm trying to go for here is that if you have an elevated, very elevated serum glucose, your serum glucose is going to actually start spilling into the filtrate, i.e., the urine dipstick can show trace glucosuria. And the essential physiologic concept that explains this phenomena is going to be splay. Now, the mechanism here for splay is kind of twofold. Number one, why do you have splay? Why do you have splay? We'll look at a chart, but the reason you have splay is because you have this low affinity of sodium and glucose co-transporter. They're kind of transiently attached. Thus, near your transport maximum of glucose, which basically means the transport maximum is going to be that threshold in which glucose can no longer be pulled back into the body from the urine. Near Tm of glucose, essentially, there is this transient kind of affinity, and glucose will be excreted into the urine because there are few remaining binding sites where it may reattach. Okay, so that low affinity and the fact that as you go towards the Tm, both of these contribute to splay. Now, secondarily, the heterogeneity of nephrons, the fact that all nephrons are not created equal, also is going to be a mechanism behind splay. And so as we recognize that the Tm for glucose is going to be essentially reflective of the whole kidney, and that whole kidney transport maximum is basically the average of all of the nephrons. So some nephrons will reach Tm and give you glucosuria very quickly. Well, very quickly. Whereas some take a little bit longer. So twofold concept: affinity for the sodium glucose transporter, as well as the heterogeneity of the nephrons. And this is going to be from your boron and Bo-Peep big physiology textbook. But essentially we see on the x-axis, this is how I like to tell you to answer all USMLE questions. On the x-axis, you want to orient yourself. This is plasma glucose. And on the y-axis, you have filtered load, reabsorption, or even excretion. But basically, has all these concepts that we talked about of glomerular physiology. At this threshold of about 200, you start having threshold of 200 serum glucose. You start having some glucose that starts going into the pee. And at this threshold, we try to say that the filtration is equal to reabsorption. The amount of glucose that is filtered is going to be reabsorbed. But as we start increasing from that 200 number, well, yeah, if we get to 250 to 350, we are going to be in this gray zone that we talked about called splay, in which you likely will have a little bit of glucosuria. And as the serum concentration of glucose increases, you will eventually reach Tm, and Tm, which is around 350 serum glucose, your filtration is going to just outweigh your reabsorption. That means what? That glucose is going to be filtered, but man, we don't have enough nephrons and we don't have enough affinity and binding sites for the glucose to be reabsorbed. And so splay is this concept in which there's that gray zone, 50 shades of gray, there's that gray zone between 250 serum glucose and 350 serum glucose, in which you can start seeing some glucose in the pee. What are questions that they can ask? USMLE, first question that they can ask on this is the child who comes in with a new diagnosis of DKA, has a high serum glucose, and they'll ask you, what's the mechanism as to why this patient has glucosuria on the dipstick? And the answer is the same stuff we were talking about. Second question that they can ask is they can have a kiddo who has, for example, obesity, a kiddo who has acanthosis nigricans, metabolic syndrome, and they say, man, he keeps wetting the bed. And when he wets the bed, they check a glucose, and the serum glucose is, for example, 300. If they check a urine on that kiddo, guess what? The urine will show glucosuria. Why? Because you are kind of in that splay zone in which you are going to have glucosuria, okay? Or the potential to having glucosuria because your serum glucose is so high. All right, everybody. Well, everybody has been sticking around so far. And our last thing, before we stop this presentation today, our last thing is going to be going through the nephron. We're going to take a nice little trip to the nephron. So are you pumped for a field trip? Everybody in the chat, type in, I'm pumped. I'm pumped. Let's get it. Yeah. Awesome. Excellent. We have so many people that are participating. That's great. We have so many more people. Come on. I need a couple more I'm pumped. If you haven't typed it in, yeah, Tina got it. All right. Awesome. Leshna. Excellent. Excellent. We got a lot of people here today, so I appreciate everybody's participation. Excellent. Wonderful. Wonderful. Pumped like the heart. All right. So let's start with the proximal convoluted tubule, okay? Now, in the proximal convoluted tubule, here are the key USMLE points, Ready? Majority of sodium reabsorbed at the proximal convoluted tubule. That's point number one. Point number two, what you have to know is that the sodium reabsorption is coupled to the transport of other things such as glucose, amino acids, lactic acid, okay, or lactate, as well as different ions, okay? The transport of sodium is coupled to all of these ions, okay? Now, two questions that they can ask. This is going to be an example of secondary active transport. And that's high yield for you to know that this is an example of secondary active transport because we are using this basolateral sodium potassium ADPase to drive the reabsorption of the other ions. Second question is that if you cannot reabsorb all of these ions, the question that they can ask is, what is the pathology? And that is Fanconi syndrome. Now, Fanconi syndrome can be due to toxins, can be genetically mediated, and Fanconi syndrome is basically when you cannot reabsorb anything from the proximal convoluted tubule. Now, what effects does the sympathetic nervous system have on the proximal convoluted tubule? Well, the sympathetic nervous system upregulates the sodium potassium ATPase, and it enhances the fraction of sodium reabsorption. And that makes sense because you are going to need more to be coming in. As you understand, about water, chloride, and K are going to actually be reabsorbed here as well. And K and Cl actually are going to be reabsorbed via what we call a paracellular transport, in which it is between the renal proximal convoluted tubule epithelial cells. Now, the majority of the filtrate that is filtered and reabsorbed, what do you think? By the end of the proximal convoluted tubule, what do you think? Are we hypoosmotic, hyperosmotic, or isoosmotic? And I actually gave this answer already, but let's see if you were listening. Majority of this filtrate, is it hypo, hyper, or iso? And I'm getting a lot of isos. Excellent. Very good, guys. Wonderful. All right. And so the majority of the fluid by the end of the proximal convoluted tubule is isoosmotic. And that is high yield for you to know that it is isoosmotic. Continuing on, let's go through a USMLE question. A patient with diabetes is going to be on a new drug, and this new drug affects the proximal convoluted tubule. What is the likely mechanism of the drug? So diabetes. What we are going to see in diabetes is that we need to reduce sugar concentrations, right? How do we reduce sugar concentrations and relate it to nephrology? Well, you pee out the sugar. Oh my gosh, there is a medicine that can help us pee out the sugar? Yeah, exactly. It's going to be the SGLT2 inhibitors, okay? And the SGLT2 inhibitors make us pee out the sugar and thus reduce our serum glucose levels in diabetes. The SGLT2 inhibitors all end in flozin. Canagliflozin, for example, or Invokana. Okay, that's the brand name. But canagliflozin, everything flozin. And so canagliflozins, or all the flozins, inhibit SGLT2. And SGLT2 is actually a transporter, a sodium glucose transporter that is going to be in the nephron at the proximal convoluted tubule. So that's very high yield for you to know. And this is how physiology relates to pharmacology on the step one. Now, high yield for you to recognize is that with these flozin medications, a very common side effect and relative contraindication is the risk of UTIs. Remember, if you are going to be glucose uric, i.e. you're going to be peeing glucose out, bacteria is going to love that. And when bacteria loves it, you got it. You can have a predisposition of infection. Lastly, I want to let you know that bicarbonate is going to be reabsorbed in the proximal convoluted tubule via a luminal carbonic anhydrase and an intracellular carbonic anhydrase. As you can see, this luminal carbonic anhydrase takes bicarb that is in the tubular fluid, and the luminal carbonic anhydrase is going to do its thing and do its reaction and cause us to make carbon dioxide. This carbon dioxide is going to go and get affected by the intracellular carbonic anhydrase. And this carbon dioxide plus water actually is going to restart the cycle of us reabsorbing bicarb, i.e. it is going to take the H plus and that goes into the tubular fluid such that it can actually give us one more bicarb reabsorbed. And this area right here represents the fact that you are reabsorbing the bicarb in the peritubular system, okay? And so the fact that the USMLE can test is that if you have the reabsorption of bicarb in the proximal convoluted tubule, it is the filtered bicarb that you are going to be reabsorbing, and that is due to a luminal carbonic anhydrase as well as a intracellular carbonic anhydrase. Second thing that you have to know is that there is a medication which actually inhibits this luminal carbonic anhydrase. And this luminal carbonic anhydrase is going to be inhibited by acetazolamide. And acetazolamide is going to cause you to pee out your bicarb and subsequently water with it. That's why it's a diuretic. And acetazolamide, how I like to think of it, it takes a seat on carbonic anhydrase. Okay? All right, very good. Next area we're going to be talking about is that loop of Henle. Now remember that the descending limb of the loop of Henle is going to be very permeable to water, and I think of it as waterfall. So the descending limb of the loop of Henle is very permeable to water, whereas the thick ascending limb, okay, that is going to be where a lot of the action of solutes are going to be coming out, like electrolytes, okay? One particular transporter that you must go into the USMLE knowing is the sodium potassium 2-chloride transporter. And the sodium potassium 2-chloride transporter, high yield for you to know, is going to be inhibited by loop diuretics. And loop diuretics are things like furosemide, torsemide, and ethacrynic acid. And that's USMLE questions for you to know that loop diuretics are going to be known as furosemide, torsemide, and ethacrynic acid, and it inhibits the sodium potassium 2-chloride transporter in the thick ascending limb of the loop of Henle. Okay, this is the diuretic that we use in the clinical setting when we want to get fluid off really quickly. We use Lasix, which is furosemide. We use it very quick, and that takes a lot of fluid out, makes you pee out. So in a patient who has heart failure, for example, who is very fluid overloaded, we're going to use the diuretic furosemide for the relief of the fluid overload, okay? And so descending limb, permeable to water, ascending limb, permeable more to solutes. Think about this important transporter. All right, next area that we're going to be talking about is the distal tubule. You're like, I'm really tired right now. I'm really tired. Well, come on, get energized, right? We're going to be almost done after we talked about the distal tubule and the collecting duct, and then bye-bye, see ya, right? No, I'm just kidding. So distal tubule, what we have to recognize is that there is an important sodium chloride symporter in the distal convoluted tubule. Now, the symporter, which is the sodium chloride symporter, that is actually inhibited by thiazide, and the name for thiazide is basically hydrochlorothiazide. Hydrochlorothiazide inhibits the sodium chloride symporter. Now, can I make a little riddle for you? Furosemide is to the ascending loop of Henle, as thiazides are to the distal convoluted tubule. Furosemide and loop diuretics inhibit the sodium potassium 2-chloride transporter, whereas thiazide diuretics inhibit the sodium chloride symporter. The parallel, the compare and contrast, that's how you study, that's how you promote memory. And so this section is impermeable to water. You're pulling out more solutes, and that's why your osmolality actually decreases even further because you're pulling out so much solutes. In fact, a little fun fact, the distal convoluted tubule has the lowest osmolarity of the entire nephron, and that's high yield. Now, one other concept that I just want to illustrate right here is the fact that parathyroid hormone actually acts at the distal convoluted tubule. So this is a good endocrine tie-in for your step one, is that if they ask you, what is the mechanism by which parathyroid hormone increases the calcium reabsorption? Well, yes, it has an effect on the proximal convoluted tubule because a lot of electrolytes are reabsorbed, such as calcium, at the proximal convoluted tubule. However, parathyroid hormone primarily affects the distal convoluted tubule and causes you to reabsorb that calcium, okay, at the distal convoluted tubule. And that's high yield for you to know. Okay, all right, excellent. Next area we are going to be talking about is the collecting duct. We are almost done. We are almost done. And there are two cells in the collecting duct, okay? Two cells. And that is going to be the principal cells as well as the intercalated cells, okay? Now, the first thing that I want you to know is that principal cells are all related to aldosterone, ADH, and subsequently aquaporins. Whereas intercalated cells, they're all about acid. So let's start with the principal cells. The principal cells are going to be controlled or be affected by the principal cells affected by aldosterone, okay? Now, aldosterone is going to cause you to upregulate ENaC channels. And the USMLE really likes to know that what is the mechanism for the reabsorption of the sodium, okay? The reabsorption of the sodium is going to be via aldosterone promoting ENaC channels to be inserted into the lumen of the principal cells such that you reabsorb the sodium. Very high yield for you to know. Now, a patient has an aldosterone secreting tumor. What effect does this have on principal cells? Well, I just gave you the answer, and that is the upregulation of the ENaC channels via the principal cells. Now, why don't we answer this? What effect does ADH have on the principal cells? Why don't you guys put that in? And I'll answer your guys' question soon, but why don't you guys put that in? What does ADH do to the principal cells? What does ADH do? Insertion of what? What protein? What do you guys think? Yes, people are putting it in. Yes, very good. Sarah, excellent. Yeah, be confident. Yes, wonderful. So yes, you have the insertion of the aquaporins. So aldosterone causes increased ENaC, whereas the ADH causes the increase of aquaporins. Aquaporins all related to water. The receptor that ADH acts on, again, this is USMLE first aid endocrine. I'm not BSing you here. The receptor is going to be the V2 receptor. And the V2 receptor is going to be the receptor that ADH acts on in the principal cells. And the V2 receptor acts via a GS pathway. Now, a biochemistry integration for you. What amino acid is the precursor for ADH? And that is going to be arginine. Arginine is the amino acid that is a precursor for ADH. All step one, integrative, question-based, active recall. That is the name of the game, ladies and gentlemen. So why don't we go on to this question right here, okay? And I want you all to take 30 seconds and answer this question. So within 8 hours following large intravenous aldosterone infusion, which of the following are clinically evident? All right, wonderful. Why don't you think about this? And just to give you a time check, we're going to be done in just about less than 10 minutes. So wanted to let you all know that. Thanks for sticking around. So go ahead. I'll be quiet. All right. I need more people to answer. I need more people to answer. We have about 50 people in this room. Come on. All right. Yeah. Awesome. Wonderful. And the answer is going to be C. Ladies and gentlemen, please know that if you know aldosterone and the renin-angiotensin-aldosterone system, you will do so well on your step one. Why? It's an important concept. There are many questions that are derived from this. Well, let's go through it. Ready? Aldosterone brings in the sodium from the urine. It brings in your sodium. And what does it make you pee out? potassium, and hydrogen ions. Ooh, whew, gotta know this. Wait, so you're telling me, if I have an aldosterone secreting tumor, I am hypernatremic, hypokalemic, and I have a metabolic alkalosis. Yes, you're absolutely correct. In cases of primary hyperaldosteronism on your step 1, this is going to be a patient who has what we call Conn syndrome. Conn syndrome patients, they're hypernatremic, they're hypertensive because with the sodium comes the water, and they're hypokalemic and metabolic alkalosis. Very important for you to know. Well, what about if you have, how about this? The other opposite, adrenal insufficiency. Say you have, for example, the severe form, Waterhouse-Friderichsen syndrome, USMLE tie-in, Neisseria gonorrhea, hemorrhagic infarct of the adrenal glands. Or say you have Addison's disease. Addison's disease, USMLE? Yes, exactly. Addison's disease is when you have primary hypoaldosteronism. And in this case, you're going to be hyponatremic, you're going to have a low blood pressure, and you're going to be hyperkalemic with a non-anion gap metabolic acidosis. So here we go. States of aldo excess is going to cause you to have a metabolic alkalosis. Why? Because you're peeing out a lot of H+. States of aldosterone low, metabolic acidosis, and because I'm all about the details, non-anion gap. This is how nephrology relates to acid-base, okay? Excellent. So just finishing up here, what I want you to know is that here we have the intercalated cells. The intercalated cells is going to deal with acid. Remember, principal, aquaporins, ENaC, right? Whereas intercalated, they're all about acid, and this is in the collecting duct. As you see, we do not have a luminal carbonic anhydrase. The luminal carbonic anhydrase was in the proximal convoluted tubule. Here we have a intracellular carbonic anhydrase. And this intracellular carbonic anhydrase makes you pee out your excess acid, And we have buffers in our body, H2PO4, ammonium from the kind of correlated to the urea cycle, but these are going to be mechanisms as to how we buffer the H+. And so if I ask you, what role does aldosterone have on the alpha intercalated cells? What role does the aldosterone have on alpha intercalated? Does it upregulate them or downregulate them? What do you think, guys? Does alpha intercalated cells, what does it do? And people are so right when they say upregulate. Yeah, remember, it is going to upregulate the H-ATPase. Remember, aldosterone brings in sodium and makes you pee out potassium and makes you pee out hydrogen ions. And the upregulation of the H-ATPase is the mechanism. Aldosterone increases the H-ATPase. So in summary, intercalated cells are all about acid-base regulation. Well, ladies and gentlemen, guess what? We did it. We went through the whole nephron, starting from proximal convoluted tubule to the collecting duct. I want to thank you so much for joining me today on this, with this review, okay? Please stick around for just a second because I want to end on a very positive note, okay? And I want you to recognize that your positive action combined with positive thinking is going to result in success. And I'm so humbled by you all joining. And a very, very, very special announcement is that next weekend, I'm actually going to be doing a webinar. And it's going to be next Sunday. And what we're going to be doing is we are going to actually be reviewing the top misconceptions. Basically what I did, I went through all of the question banks and I figured out what are the hardest topics from the question banks as well as the USMLE content outline. And we're going to review the most difficult and most misconceptions from each organ system. We're going to get the Hi Guru notes when you register, and it is going to be next Sunday, bright and early, 8:30 a.m. It's going to be for 3.5 hours. I'm actually running a special as I teach many USMLE classes. I usually charge $98 for this session. However, I encourage you all to sign up. And for you guys joining today, the registration fee is $65. I'm going to email you the link, but right now I'm just going to copy paste it into the chat box right here. And feel free to click on the link and register today. I'm only going to be keeping it a very small classroom, not this big webinar style, but just a really intimate group of students. I've been humbled. You know, last week we had a rapid review session, and we got so many good testimonials from that rapid review session. So, you know, today the one ask that I have is, you know, first off, just stay positive in your step one preparation. If you have any questions, definitely reach out to me. Connect with me on social media. I'm on Twitter, Facebook, Instagram. I have daily USMLE questions that come out. And I just want you all to recognize that, yes, it's a very stressful time, but if you just take actionable steps and you apply yourself, you apply the content, you will do really, really well. So feel free to definitely write a review. That would mean so much to me. Let me actually type in the link where you can write the review on Facebook. That would be so awesome if you can. And unfortunately, I have a question from somebody. Can we get today's webinar video recording? Actually, due to copyright, we are not going to be sharing this video recording. However, if something changes, I'm definitely going to let you know, but just wanted to answer that question. If you all have any questions, please stick around now and type in the chat box. Otherwise, you all are free to go. Thank you so much for joining, and I'm going to stick around and answer any of the questions, okay? But thank you, George. Thanks so much for attending. All right, awesome. We have so many people that are just exiting. If you have any questions, definitely let me know, okay? All right.